Saunders Institute Open Seminar series. I'm going to be your chair today. My name's Liam Gabb. I am a PhD fellow here at the CSI, working on the area of dementia and palliative care, using mixed methods, including health economics. So I'm especially interested to hear the talk today. I hope everyone is managing okay in the heat. It is very warm here in London. And as you know, every month the Cicely Saunders Institute hosts a free seminar with speakers presenting on a range of palliative care and rehabilitation-related research topics. The seminar consists of a 40-minute presentation, followed by 20 minutes for questions and comments afterwards. You can ask a question by using the raise your hand function or writing your question in the chat box after the presentation. Today's seminar is completely virtual, so please can everyone online make sure they're muted and that they remain so throughout the presentation. Also, please note the seminar will be recorded for our faculty YouTube channel for others to be able to catch it later. So please do not try to record the seminar yourself. Right then, with the admin out of the way, I would like to introduce our speaker today, Senior Lecturer Peter May from King's College London. This presentation will focus on recent evidence that highlights credible causal estimates of specialist palliative care at home and in hospital on costs and outcomes in England. I'll hand over to you, Peter. Thank you very much.
Thanks, Liam. I chaired a talk Liam gave 2 hours ago, but he didn't tell me that he was going to be returning the favour, so I might have handled things differently if I'd have known. Okay, so just before you mute, Liam, can you tell me if you can see these slides?
Yes, we can see them, and they're in the right view.
Okay, perfect, thanks. So good afternoon, everybody, and thanks to whoever issues the invitations for the invitations to talk. So yes, so this is reporting an economic evaluation that we did over the last year, and then also trying to think through some of the next steps. So the important acknowledgement is that this work was funded by an NIHR policy research unit, led by Catherine Sleeman in the CSI, Fliss Mercer in York, and Catherine Walsh in Lancaster, that's worked with the DHSC to answer sort of policy relevant questions in palliative care. And they had asked us the question probably more than a year ago now, is specialist palliative care in England cost effective? And so what I wanted to talk about today, so before I go any further, sorry, this work was co-authored with these 7 other people, or 8 other people named here. So I'm grateful for their input. So if you like what you see, the credit is shared with them. And if you don't, then it's my fault because they've not approved these slides. And then what I wanted to do today really was to talk about that paper. I was asked to talk about the paper, but I thought with a bit longer to talk about and with a wider audience for people from different backgrounds, I wanted to first take the time to place it in a bit of context. So to talk very briefly about what we're doing with economic evaluation and what economic evaluation and palliative care evidence base looks like, then to talk through the paper. But then I think hopefully, like any good piece of research, the paper raises as many questions as it answers. And so instead of repeating work that we've talked about quite a lot over the last year, or only to repeat it, to think about what comes next as well. So just briefly to start with the context. As many people in the room will understand, but not everybody will, economic evaluation has 2 components. So yes, as economists, we're interested in the effect of an intervention on costs, but we're also interested in the intervention's effect on outcomes, for example, patient survival, health-related quality of life, and so on. And when we measured those 2 effects, we can combine those to place it somewhere on this graph, graphing effects on costs on the vertical y-axis and effect on outcomes on the horizontal x-axis. You end up in one of sort of 4 quadrants. So you can see in the southeast quadrant, this is something that's cheaper and better than what we're doing at the moment. It's a no-brainer. In the northwest quadrant, this is more expensive and worse than what we're doing at the moment, so we shouldn't consider that. And all of the difficult and interesting questions happen in the northeast and southwest quadrants. It costs a bit more, we get a bit more, we save some money, but we're worse off in other ways. And the reason why we're doing that is what economists call scarcity. Health-related demands will always exceed our available resources. So no matter where we set the budget, it is an inescapable fact of life that we have to make decisions in allocation. We will fund some things and not others. And economists, every health system in the world funds some things and not others. The question is how you make those decisions. And economists would say that it should be done on the basis of opportunity cost. So is what you're choosing to fund better value than the next best alternative? So those unfamiliar with health economic methods, this may seem sort of somewhat difficult to get your head around, but I always like to emphasize to non-economists that everybody is practicing economic evaluation every day. Everybody on this call has a finite amount of money in the bank, time in the week. You spend that time and money on some things at the expense of others. And every one of those decisions has an opportunity cost. So whether it is a daily cup of coffee, from the place on the corner, or buying a house, in either case, you are spending more. You are spending your scarce resources in the hope of improving your outcomes, and that it's also possible to think of everyday examples for the other quadrants. If you move from a well-established brand to a generic alternative, then you'll save some money, but you'll be worse off in other ways. No-brainer options are regrettably rare enough in real life, but they do exist. For example, quitting smoking will save you money and leave you healthier, whereas taking an African elephant as a house pet will both adversely affect your quality of life and increase your cost, particularly around circus peanuts. So when we think about interpreting the results of our economic evaluation, it's mostly helpful, I think, to think about what is happening in the northeast quadrant. In healthcare, as in life, most decisions are spending more to get a bit more. And this is a point made in a recent editorial in Palliative Medicine by Eric Finkelstein, who asked the question, palliative care, is it the holy grail of healthcare interventions? And Eric's point is that actually very, very few interventions in the history of healthcare are in the southeast quadrants, both cheaper and better than what we're doing at the moment. Really, realistically, almost all decisions that we make in healthcare, as in life, are in the northeast. We spend a bit more to get a bit more, whether that is hip replacements for better quality of life, vaccinations for longer and survival, and so on. The one last important contextual point I wanted to briefly go over is when we say we want to, if we want to get more for our money, what does more mean? What goes on the x-axis? How do we measure that? Normally, in the UK at least, and following the guidelines for the people who support decision making for the NHS called NICE, we use the quality adjusted life year, which is best understood as 1 year lived in full health. And this, therefore, is a measure that it has elements of both time and quality of life. So you can think of a treatment like this that extends survival on the x-axis by 5 years. It has no impact on quality of life on the y-axis. So 5 times by 0.8 is 4. So you get 4 QALYs. There's the surface area of that blue rectangle. This is an alternative treatment that has a quality of life improving effect from 0.6 to 0.8, but has no effect on survival, which would gain you 3 years in this particular example. And often, of course, life is quite messy, and you can have an intervention that does a little bit of both, and people's quality of life is going up and down, and so on. But again, the quality gain from the treatment is the surface area of that blue shape. And so how do we interpret those results? There's no correct answer to that. And the more money you have, the more you may be willing to pay per QALY. In the UK, we generally think of between £20,000 to £30,000 per QALY. So if palliative care is going to cost more to give us more, those are the kind of benefits we need to be seeing. Then I said that I wanted to talk a little bit about the evidence base, and so where does palliative care sit in our interpretation of that kind of way of thinking? So there is a large number of observational cost studies, two well-cited systematic reviews here by my friend Samantha Smith in 2014, and then more recently by Julietta Luter and others 2021. And when Samantha did her review, and with Charles Norman in CSI as well, they found 46 relevant papers. And when Julietta updated that search 7 years later, she found there were simply too many papers to read. So instead, they had to do a review of reviews. So there is a very large volume of observational cost studies out there, and they all tell a very similar story, that home care, hospital care seems to save money. There's not really so much evidence on other models of care, such as inpatient hospice. Most people on the call probably be familiar with the trial evidence, and in particular Cochrane reviews, both of these originating in the CSI as well, that show that trial data is associated with better outcomes for patients in terms of better pain and symptom scores in particular, and a higher probability of dying outside hospital. So if you take that evidence at face value, you could be forgiven for wondering what the problem is. There's this huge body of evidence that says palliative care saves costs. There's the trial saying that it makes better outcomes. So maybe the answer to Eric's editorial is yes. This is the Holy Grail, actually, and we're in the southeast quadrant, and this is a no-brainer. I think probably there are two reasons to give us pause of why it is unfortunately not that simple. The first is the quality of that cost evidence. So both of these reviews don't have a quality threshold. They're almost all observational, meaning that there's substantial unobserved confounding problems, particularly around how sick those getting palliative care are compared to those who don't. And then there are also sampling problems, lots of studies looking at the last 3 months of life, last 6 months of life, which is a good sampling frame if you want to describe or quantify a problem. How many people die in hospital? It's not a good sampling frame for an evaluative question. Does palliative care affect dying in hospital, for example? And the concerns of the quality of that cost evidence is kind of reinforced when we go back to the trial data, because that's much more ambiguous. They find that while there has been more quality of, there's improved quality of life and reduced risk of hospital death, the evidence is not there that it's not that palliative care is cost effective. And that sort of feels like mixed signals, because I've always thought, well, if you're making the patients better and you are keeping them out of hospital, surely your probability of cost effectiveness is high. And it's not simply that they've done lots of cost effectiveness studies that find no effect. It's more that very few of the trials included comparatively did cost effectiveness analyses. And so it's the size and quality of that evidence is not compelling, not convincing either. And then the second problem is a lack of what we would call full cost effectiveness studies. So there's been a lot of papers saying, does palliative care affect costs? But there's been very few looking at costs and outcomes at the same time and placing the intervention under evaluation in one of those quadrants. This slide has served me very well over the years. It's about to become out of date, I think, as new systematic reviews come out, and there are slowly, thankfully, more cost effectiveness analyses of palliative care happening. But in the most recent published systematic reviews, you can see the number of full economic evaluations of palliative care compared to other clinical areas is markedly low. And so that's then a big problem if the situation is, as Eric says, that as with most healthcare interventions, we're in the northeast quadrant. If this thing costs more and we get more, we might well be all right with that as economists, but we need to know how much more we're getting for our money. So if we're only looking at the costs and we haven't quantified those benefits properly, then we don't know how to address that question mark. So therefore, that's been a whistle-stop tour, I'm afraid, but just trying to give context to those who might have previously been lacking it, that the Department of Health in England asked that our policy research unit, is specialist palliative care for England cost effective? And I think the honest answer, or the short answer, is it kind of depended where you look. You could definitely emphasize the lower quality evidence and say that by volume of studies, this appears a no-brainer. It is palliative care is some kind of holy grail because there's this huge number of studies suggesting cost saving. But if we take a more nuanced view of that evidence, then we kind of see more mixed signals. So you could say, well, we don't know the answer to the question, but we didn't really want to tell them that either. It's probably perhaps our job to be able to answer this kind of question. So that's what we decided to do instead, was rather than say on the one hand this, on the other hand that, we would try something new and try to push the evidence base forward a bit. So that's how we came to write this paper, which was out in Palliative Medicine now, I think, in the springtime. I've been working on it for so long that I've sort of lost track of how it fits into linear time. So to repeat, the kind of context therefore is the cost effectiveness evidence is mixed, but we do have this high quality evidence or persistence evidence in Cochrane reviews on place of death. Both home and hospital based specialist palliative care are found to improve people's odds of dying at home alongside quality of life improvements. Well, if that place of death effect is true, then there must be an economic implication. If you are less likely to die at home, then almost by definition, you are spending less time in hospital, which means lower hospital costs. On the other hand, it means you're spending more days at home. You're placing a higher burden on primary, community and home care, as well as family informal care. And of course, there's the costs associated with the intervention itself. If an intervention improves your odds of dying at home a bit, but costs a lot, then we're less likely to be interested in it than if it is hugely effective and very cheap. So our sort of concept was to say, well, if we have this strong causal evidence on place of death, can we leverage that in order to deliver a more convincing answer on the cost effectiveness of hospital and home specialist palliative care? And the next part of our thinking here is to say, well, we know descriptively a lot about the kind of patients that we're interested in. We know where people die. That's one of the most basic health statistics recorded in England and elsewhere for the population as a whole. And we know where they spend time beforehand. We know how often they go to hospital, and we know how long they spend there. And so using those data, we're able to build what is called a decision model. There are 4 places that a person alive near the end of life can be. They can be at home, they can be in a hospital, in a hospice, or in a care home. And it is possible to move between those places on a day-to-day basis, and it is possible to die in any of one of those places as well. Of course, I think it's about 99% of deaths occur in one of those 4 places. So if we know where people spend time, how long they're there, and where they die, then that kind of gives us 3 outcomes on which to anchor a model: the frequency of admissions to hospital, to hospice, to care home, the time spent in those places, and the deaths in those places. And for a given population of people, there is only one set of probabilities for all of the arrows in that model that will satisfy all of those outcomes. And so we got the best available data we could on those 3 parameters of interest: where people die, their hospital activity, their care home and hospice activity. And we solved the simultaneous equation for probabilities that will give us those outcomes. And then we overlay the treatment effect from the Cochrane reviews on place of death. So the way that works is to say that for hospital-based care, we're going to hold all of the probabilities in the model constant. Hospital specialist palliative care does not change your probability of dying in a hospice on a given day down the line, or care home on a given day, but it does on a given day change your likelihood of hospital discharge. And for home specialist palliative care, model. We did the reverse. We said that the intervention can affect your probability of hospital admission, but no other probability in the model. You could argue things differently. You could say that hospital palliative care also prevents readmissions, for example, or makes hospice admission more likely. We didn't feel that the quality of data were necessarily there to support that in the same way. So we change only one probability in the model each time until we get the place treated and untreated place of death reflects the Cochrane review evidence. There's a challenge in presenting something as complicated as this in about 20 minutes. So there's a lot going on here that I've not had the time to either talk you through or subject you to, depending on your perspective. Fortunately, now the paper is published and the monstrous Excel spreadsheet that supports it is also available open access online, then I would encourage you to seek out a lot of those sort of more technical and specific methodological questions, although of course I'm happy to speak to them as well. Two important sort of conceptual points are: we fix survival by construction in all scenarios, so any differences we see are never because the patients are living longer or shorter, for example, because when you're out of hospital, you're then less likely to die. We just assume that there's no evidence saying, well, very limited evidence of specialist palliative care affecting survival in either way. So we'll just say there is no effect. And the other thing is that while NICE is most interested in system perspective, we were conscious of the importance of informal care perspective as well. So we did a sensitivity analysis incorporating that. So here are our main results from the paper. The black table on top is showing the results of the home specialist palliative care. We're finding at the individual level, there is a saving of about £8,000 per person on average, moderate quality of life improvements in the form of a small QALY rise, and our incremental cost effectiveness ratio, the cost per QALY, is negative. That means that we have both improved quality of life and we've reduced costs. So a negative QALY is, in fact, a no-brainer in that northeast quadrant, that this thing is, better outcomes for lower costs. Hospital specialist palliative care in blue, very similar results of interpretation. £6,500 saving per person, modest quality improvement. And again, this is what economists call dominant, better outcomes for lower costs. So remembering that this all comes from Cochrane review evidence on place of death. If we think the place of death effects are true, then hospital specialist palliative care is dominant and home specialist palliative care also highly cost effective. It's worth remembering that these estimates are from trials, so it's all based on an assumption that the intervention is going to be provided in a timely way with good coordination, regular return visits, and so on. We also wanted to estimate what this means at the population level, so we did a calculation here as well. If you take across the two models of care, we estimated specialist palliative care annually saves the English NHS more than 20,000 hospital deaths, 1.5 million hospital bed days, and £800 million. This did incorporate some stylized idea that not everybody who gets specialist palliative care gets it in a timely, adherent way. So this is not simply the individual treatment effect multiplied by the number of people who die. We are moderating for sort of heterogeneity of timing. And so our thought on this, therefore, is that the headline from the paper is that home and hospital specialist palliative care do appear highly cost effective for the NHS. They are at the mean in that southeast quadrant of better outcomes for lower costs. Mainly due to the fact that if you are reducing deaths in hospital, you are by definition reducing time in hospital near end of life, and that hospital cost saving absorbs any increased costs related to additional home and primary care. We also did the sensitivity analysis on unpaid care costs and to how we modelled survival, and the results are essentially the same. So with informal care, of course, there is a greater burden on carers if people spend less time in hospital and more at home. But in the grand scheme of things, that money is more than outweighed by the hospital cost savings. So in circumstances where we're worried about carer burden, the answer would be to think about how we redirect some of those cost savings to better support carers rather than to keep people in hospital to minimise the unpaid care they need. So the big strength of this paper is, I think, that, you know, I have in the past received reviewer comments where they say you can't say palliative care is cost effective because the Cochrane review evidence is ambiguous. Well, I would argue that this kind of ends that debate in that if we think the Cochrane place of death estimates are true for England, then our results are more or less true because we know where people spend time, we know how often they move between these places, and we know where they die. An additional strength of this is that we don't need very complicated data parameters to do something similar for other countries. One or two people already expressed an interest in doing that, and I'd be happy to think about doing it in others. The primary limitation is hopefully obvious at this stage, which is, well, are the Cochrane review estimates of place of death effect actually true for England? If they're not at all relevant, then I wasted an awful lot of 2025 and we need to do something else. Perhaps more likely, they are true for some people, but we're not entirely sure they're true for everybody. And so we need to think about how do we interpret these mean effects, the distribution behind them, and treatment effects heterogeneity. We also, of course, need to think about the people who are not getting specialist palliative care. So survey data says about half of people who might benefit who go to hospital get hospital specialist palliative care in England, and a similar proportion at home get home specialist palliative care. So who are the half who are not getting it? Would they benefit? Would the system benefit? And so on. For this final part of the presentation today, I'm going to focus on these 2 points circled. That is to think about how do we start to think about those for whom the difference is greatest and those for whom the difference is perhaps 0, and what are we going to do about that? Sorry, I can't find a mute button for my cough while I'm in presentation mode. So then finally, I wanted to not just rehash this work of the last year, but to think about where we might take it next. And so this is work in progress. That is a simulation study. So our paper used aggregate data and mean estimates of place of death effect to get mean estimates of cost saving. So they rely on this kind of idea. The Cochrane review place of death effects are true on average for people with palliative care needs in England, but it's reasonable to doubt if they are true on average. Cochrane reviews get results from trials. Well, trial participants are probably on average more likely to be happy receiving palliative care. They're perhaps more likely to want to die at home than the general population. And then the other thing is specialist palliative care's ability to affect place of death won't be fixed either. So if all of the effects are only driven by place of death, and I'm not saying they are, just that that's what the Cochrane review has, if specialist palliative care's effects are being driven by changing place of death, then World Health Organization guidelines say that you should get palliative care from the day of diagnosis. But on the day you get diagnosis for example, cancer, you might want palliative care input for pain management. It seems rather less convincing to me that palliative care will have a big effect on your place of death that early in the disease trajectory. It seems much more plausible the place of death effect will become larger the more advanced in your disease trajectory you are. So what I'm really trying to do here is to try to start thinking about stress testing this the paper to say, well, what are the underlying limitations of the Cochrane review evidence, and what happens if we start pulling out some of those Jenga blocks. So in particular, I was going to focus on 2 here. What if your preferred place of death is hospital, then place of death effect presumably wouldn't work. And what if you are not that sick? It's reasonable that the place of death effect would also not be so strong. So I am rerunning the models, but the intervention will only work for you if you're happy to die outside hospital or you are approaching the end of life where that is unobservable. So this is a simulation study focusing for the moment now only on the hospital model of care. I'm using Claude AI in order to generate the data. So a micro simulation approach where we generate 25,000 individuals, which is sort of approximate to the patient count of the kind of hospitals data that I've been working with recently. We first model age and sex, and then based on age and sex, race and ethnicity, and then based on age, sex, race and ethnicity, the deprivation, based on all of those things, the diagnoses and so on. So we build a data set of 25,000 people where we know their socio-demographics, their clinical profile, their preferred place of death, and how long they stay in hospital and where they die. And those data should look like what HES data look like. It's based on a combination of survey data and publicly available NHS and HES data. And then we apply the treatment effects from our paper, but now palliative care affects place of care differently. In the first case, it still works for everybody. In the second case, it only changes your likelihood of leaving hospital if you are happy to die outside hospital. In the third, it only gets you out of hospital if you are approaching the end of life. And then what if both of those constraints are applied at the same time? Please do not interpret the results I'm about to show as being in any way true. They're just exploring, trying to get a handle on how big these problems potentially are. So here are the results. The first line is saying if we rerun the results from the main paper, but we do so now where people get palliative care at different times in the hospitalization, the results are less impressive than the trial data, because if you get palliative care later in hospitalization, it's not as cost effective, but nevertheless, it still appears to be dominant. If we restrict it to people who want to die, well, the effect only works for those who are happy to be discharged to die outside hospital. Its effect is less again, it's less cost effective, but still dominant. That doesn't really affect our results very much. It's when we start to constrain by how close you are to the end of life that the effect really becomes more complicated. So the third line is saying what happens if palliative care only changes your probability of hospital discharge if you're near the end of life. And then it's still looking like reasonably good value care. NICE should fund it on the basis of this simulation model, but it's no longer a kind of overwhelming holy grail kind of narrative. And in the final line where we apply both constraints at the same time, you have to be both happy to die outside hospital and approaching end of life. Then the cost effectiveness is not so clear. So as we're moving down the table, we're making it we're introducing more constraints, making the story more complicated of how and when palliative care might have an effect. So we'd expect the general trend that we see, that palliative care is less cost effective as we move down the table. The encouraging thing, I think, is that it's still within the realms of reasonable cost effectiveness. 20,000 a QALY, 30,000 a QALY is generally considered to be reasonably good value care. But it is, I think, illustrating the point that I'm worried about, which is once we start to complicate the story and say specialist palliative care will have more of an effect for some than others, then that will also complicate the story that we get the story that we've started, I should say, with the paper. So, as I say, by restricting the number of people who will benefit, in inverted commas, by getting out of hospital, according to their place of death preferences and their proximity to death, we start to get a slightly more complicated story in the result. In particular, I think it is the question of how likely palliative care is to get you out of hospital relative to how sick you are that appears to be the key sort of economic question. And so I am in the process of trying to dig around these questions, both with some better input data, if I can find the right literature, but also some better, more judicious modelling of the inputs with the long-term aim of trying to do some research that will lead to the story that we started in the paper, getting some actual individual level real world evidence that both supports specialist palliative care receipts for those who would do benefit from it as currently practiced, but also thinks about then who are the people who are not currently benefiting and or not currently getting it at all, and how do we think about improving the care that those people receive near the end of life as well. I think that therefore my sort of thinking at the moment is that it's reasonable to ask if palliative care is a holy grail solution for everybody. It seems highly implausible to me that palliative care or anything else in our complex populations would be, because access and effectiveness will vary across individuals. But at the same time, those kind of the basics that I introduced at the start are very clear. We know that there is recurring evidence palliative care improves pain and symptom management, and we know that the costs of providing care in the last year of life are extremely high. I think in the English NHS, it's about £7 billion per year spent on emergency care in the last year of life. So I think that's probably roughly £1 million since I started this presentation. If given the size of those numbers, it doesn't take a huge change in the odds of hospital discharge for a hospital-based intervention to be cost effective, because the costs of staying in hospital are enormous. A small, not terribly costly intervention to get people out quicker can plausibly be cost effective. And so I think my kind of feeling is that we are in the southeast quadrant. It is dominant for some people, but not for others. And so our longer term aim should be better identification of that group who will definitely benefit, and then better evaluation, understanding, and evolution of care for those who are either not benefiting or not currently receiving it. I reiterate my point that I think our first paper is, dare I say it, quite important, but it is only the first of what is hopefully many steps. Okay, thanks.
Amazing. Thank you very much, Peter. That was really, really fascinating. And it's always so impressive to see that work and that you make something so complicated so clear. Now I'd like to invite questions for the next 15 minutes. If you're online, please feel free to either raise your hand or pop something in the chat and I will try and read it out for Peter. Oh, yeah, I can see Angela's got their hand up, so I'll let you go first, Angela. Do you want to unmute and ask your question? And introduce yourself first, please.
Hi, my name's Angela Szabo. In my day job, I'm a director of finance working for an ICB, and I'm also doing a similar topic in terms of PhD, looking at value in end-of-life care for hospices specifically. So it's a related topic. In terms of how you've presented it, I've been looking at how QALY applies when we're looking at resource allocation across different areas of end-of-life care. I think it's challenging in terms of the actual QALY calculation. When you've looked at the cost base, you touched on emergency care. You didn't mention primary care or fast track continuing healthcare, and that's quite big areas of NHS spend. So I was just curious about that, about your thoughts. Thank you.
Thanks. So, I mean, on the question of qualities and end of life care. That is that topic has been a sort of a constant in the 15 years or something that I've been working in this area. People have different opinions on it. Mine is that there's sort of an interesting debate in principle, but there's not actually been that much empirical work to show how much of it is a problem really or not. And the whole the rationale for using qualities is comparability to other areas of the healthcare system. So if we're talking particularly about hospital-based care and things that we want the NHS to fund, then I think at least engaging in good faith with quality type evaluations, and then perhaps in parallel using other more context specific measures and comparing the results and seeing how much it matters. I think that that is probably the sensible way to go, rather than try to opt out entirely, particularly to opt out entirely before we've even really demonstrated whether this problem in principle exists. For the question of the different sources of costs, I mean, we essentially drew on, if you're at home, then there is a primary care cost in your cost. So we used a different study that the Policy Research Unit did, led by Gemma Clark, which I think is not a paper yet, but is out there somewhere as a report that I could find, where how much primary care do people use in the last year of life and emergency department visits without going into the hospital and outpatient care and so on. And then for every day in the model that you spend at home, you get a proportional cost associated with all of that. So it isn't like being out of home is cost-free or anything. Like, we include all of the non-hospital costs as well as the informal care costs in that sensitivity analysis. I don't know if that has answered both of the questions, but
really helpful. Thank you.
Perfect. Thank you very much. I'm now going to move on. We've got Matthew Maddox. You have a question. Do you want to unmute, or do you want me to read it out? Give you a second to read it.
Yeah, I can. Yeah, thanks, Peter. Really clear, thorough. It's not a question about this particular outcome, but I just wondered if you'd considered, in the kind of working up of this, about aggressive treatments at end of life, in that they seem to be quite well defined. They are quite binary, so you can work with probabilities, and some of them, well, they're getting more rather than less expensive, so some of the costs might be quite comparable to a few days in hospital.
Thanks, Matt. So that is, I mean, that's in some senses, is the classic way of thinking about the economics of palliative care. Like, going back to the first American study, they do an awful lot of expensive, or they certainly used to anyway, 20 years ago, expensive high intensity treatment near end of life, particularly in cancer. And so that was the guiding motivation historically of a lot of economics of palliative care studies. I think that definitely that's something that a better version of this model could include, and maybe it's something I can even try to bring into this micro simulation project. I think that it is the problem, the weakness of those kind of historic studies is a lot of them, again, antecedent cohort studies looking at people who had died and then saying, oh, a lot of these people who died had high intensity treatment near end of life. But if we didn't know they were going to die when those decisions were made, then it becomes a lot more complicated. So, but I agree, they are very expensive. So I think there would be some potential treatment effect in there, but I think that it might not be as big as the sort of historical literature would show, because once you properly account for the true positive, true negative nature of it, identifying in advance those for whom cost savings are there at end of life, we wouldn't hit the target as often as we would like, I think. Or I say we, it's my clinical colleagues, really. I don't have anything to do with that side of things.
Thank you.
Fantastic. I can see we also have a question from Richard. Do you want to unmute and say, Richard?
Thanks very much. Outstanding work, Peter. Really fantastic. And I would agree with Liam. You explained it brilliantly. So I'm curious to hear your view on what this might mean to a kind of a more global audience. As you know, I kind of work mainly in low middle income countries where 80% of people who would benefit from palliative care live. So thinking about the data sources that you've been able to draw on and the conclusions that you draw, what do you think it might mean for people in low middle income countries where we are trying to strengthen health systems by the inclusion of palliative care?
I think that the data parameters that we use are relatively simple, but I think they're not. I would not assume they're definitely routinely available in all of the countries that you were, Richard, for example. So it is, in particular, it is what proportion of people are getting palliative care. It is place of death for the population as a whole, and it is utilisation near end of life for the population as a whole. Those are the main things that we need. I think that the biggest thing though about crosswalking this kind of analysis from high income countries to low middle income countries is more to do with how those health systems work. So I think implicitly a lot of what this is showing is that the cost savings are coming from a form of over treatment. People are in hospital in high income countries when they don't need to be in hospital, but I'm not sure the extent to which that is true in low and middle income country settings in the same way. And the other aspect of this is that you sort of, so you need the cost savings. I think we get the small quality of life improvements, but you need the cost savings, I think, to drive the cost effectiveness argument. Otherwise you're in that sort of Eric space of we're just paying more to get more, like any other healthcare intervention. So I think it's a lot more complicated and difficult to think about cross-monitoring because the patterns of healthcare use and people's reliance on inpatient hospital care in serious chronic disease in sub-Saharan Africa or something is obviously very different to in Western Europe. But nevertheless, if it is possible, if there are populations who go to hospital when we could meet their preferences and their needs outside of hospital, then that economic argument is unchanged, right? If we can meet the needs outside of hospital, or we can demonstrate that we do, then we should definitely do that, because I would say palliative care is highly likely to be cost effective in those circumstances. But I mean, as you know much better than me, the combination of the data challenges to make a model like this work is it becomes a big problem, because and then finally, can we assume if the Cochrane review evidence is true, it's all drawn from Western Europe and America, so how true is it for Uganda or Vietnam or whatever it might be? So we can definitely start to look at it, but I fear that I wouldn't like to promise we'd be able to do it by the end of the summer. I think we'd find more known unknowns as we went along, I think. But obviously it should be a important long-term ambition for you and me personally, and for the field as a whole.
Perfect. Thank you, Peter. And we've got a few minutes left, so just last question I can see from Joanna in chat. Are you able to unmute, Joanna? If not,
yes,
I'll read it out.
Can you hear me?
Yes, we can. Thank you.
Headphones, apologies. Peter, really fascinating. Thank you. It's always really interesting to hear it explained in detail. Just wondering about what's possible with those micro simulation models, and whether you can look at things like, for example, how much it would cost to close an inequality gap, for example, the deprivation gap in place of death.
So the short answer is yes, you could, and that is, so again, the answers will never be true, because it's only a simulation study trying to approximate what we think the real world looks like. But that is one of the big reasons why I started doing it, and why micro simulation I think is so important, is it allows us to draw out inequities by whether it be things to do with diagnosis, for example, or social ones. The place of death thing, though, has given me a slight pause in that actually the stuff that Claude and I found, there wasn't a huge place of death by sort of social gradient, if that's the phrase I want. So and if you look going back, I was looking, for example, at what was the study that Barbara Gomez and Irene and those did, like, well, you were involved, Richard. What's that, like 12 years ago or something?
Qualicare.
Around place of death. And actually, like, there is a bit of a gradient, but it's not enormous, I don't think. So it is something we could look at. I need to characterize it better in the model, and maybe Joanna, you could help me do that by pointing to the literature in the right place. But at least in this first run, it was the clinical uncertainty was more important than the inequities angle in changing the results of our prior work.
Perfect. Thank you very much, Peter. And that about brings us up to time. So I would like to just first say thank you to everyone for attending today's seminar, but also highlight that we have another seminar taking place on the 23rd of September at 4 p.m. and details will be shared soon. So watch the mailing list. I think Therese already put in the mailing list for if you want to sign up in the chat. And do sign up to stay up to date with the seminar series or suggest future speakers you'd like to hear from. So thank you very much. You can just join me in giving another round of applause to Peter, and we look forward to seeing you next time.
Thank you very much, Liam. Thanks, everyone.
Thank you very much.